The following video will demonstrate one technique of meniscal repair. The camera is inside the knee. We can see the kneecap at the top and the groove below it. The camera is now in the medial compartment of the knee, and we can see a normal joint surface on the femur at the top, the appearance of a tear in the periphery of the meniscus, which is now being probed, and we can see the cartilage or meniscus is very unstable and can be displaced away from its capsular attachment into the knee joint in what's called a bucket handle manner. The tear runs from the anterior portion of the cartilage right through to the posterior or backmost part of the cartilage. The tear is highly unstable and can cause locking of the knee joint. The camera is now in the intercondylar area, and the hook is probing the anterior cruciate ligament, which appears intact, healthy and normal. The camera is now in the lateral compartment of the knee joint. We can see normal joint surface on the femur at the top and tibia at the bottom, and the hook is probing the lateral meniscus or cartilage, which appears normal and undamaged in this case. When we perform a meniscal repair, initially the synovium and tear site is roughened or abraded with a shaver to promote bleeding and create a healing response. Hollow cannulas are then introduced into the knee and placed around the cartilage tear, and through these cannulas double-armed needle sutures are passed. These comprise two long needles with a thread linking them. The first needle is placed at the appropriate point in the tear site and pushed through the cartilage, through the capsule, and retrieved on the outside and pulled through. The cannula is then moved a short distance, where the second needle is then passed, and the intervening thread or suture is then pulled through and tightened to create a stitch that will hold the tear site in place. The cannula is then moved to another position in the tear, and another set of needles and sutures are passed to create a second stitch. To access the posterior part of the knee joint, we place specially curved cannulas and further needles and sutures are passed into the posterior aspect of the tear. And this sequence of stitches continues, moving around the tear site until the entire meniscus has been stabilized and stitched back into position. Not all meniscal tears are repairable, and indications vary and depend on the type of tear, how long the tear has been present, what the state of the cartilage is like, and whether it is deformed or intact. But most importantly, it is the zone of the tear. The blood supply of the meniscus comes from the capsule and is present in only the outer third, and tears in the outer third have a healing potential, whereas tears in the inner third do not. Once the repair has been completed, the stability of the repair is assessed, which appears satisfactory in this case.